So, Letitia, what is the most reliable way to confirm that the tube is in place? End-tidal CO2. What about if you see it go through the cords? That's not better? No? So usually somebody says, what's the best way to confirm it? Well, I saw the tube go through the cords. But every time there's esophageal intubation, what does the operator usually think or say? I saw it go through the cords, right? So we are not reliable in that case. So we have to rely on an empiric judgment, and that's the end-tidal CO2. And so most of us have the easy caps, and even better is the continuous waveform. There was a period of time where EMS had the continuous waveform, but our monitors didn't. So it was actually kind of a downgrade in care from the street to the hospital, but now we've caught up and we've got end-tidal on all of our monitors. So either that or these reassuring boxcar morphology on the end-tidal CO2. But when is the end-tidal CO2 not going to help you? What kind of patient? Yeah, somebody who's dead. Yeah, somebody who's dead because they're not exchanging gas. The end-tidal CO2 depends on exchanging gas. Now, sometimes after 5 or 6 breaths, you start to see a little bit of a color change, but I don't find that very satisfying. So what's a way that you can immediately confirm tube placement in a patient that's arrested? Exactly. So this is not the right type of catheter. I'm talking about the ones that have the catheter tip that the nurses use for NG tube placement. But what you do is you tip the... can you hand me an ET tube, please? Yeah, so it's called a Toomey syringe, and it's got a catheter tip different from this one. But what you do is you pop the end of the endotracheal tube off, you put your catheter tip syringe in there, and if it's in the trachea, what's going to happen when you pull back? It's just going to be smooth and easy, no problem. Okay. If it's in the esophagus, though, it comes and it hard stops. I mean, it stops. You cannot pull it any further. And why is that? Right, soft-walled esophagus. So this is an immediate way, and as far as I've read, it's essentially 100% sensitive, unless there's some obstruction against the ET tube. You've got a plugged tube or a kink tube. But if you pull back smooth, you're in. If it comes back and it stops, you're in the esophagus, and that's an immediate way of knowing. The other technique is to use the turkey baster, those blue little infant suctions. You collapse that. Again, take the flange off, put that in there. If it fills up all the way, it's in the trachea. If it expands, about a third and stops, then it's in the esophagus. So that's really helpful in the full arrest patient if you're not sure if the tube is in place. Okay, so here's what I'm talking about. And see the shape of the tip here. That's called a catheter tip or Toomey syringe. It'll be usually it's with the orogastric or nasogastric tube, and that's a quick, easy way. And before we had continuous capnography, I would test every EMS tube this way. Every EMS tube that came in, I would take the syringe and verify placement that way. All right, so the next part is managing the vent. As I said, I feel like we're shirking our responsibility in emergency medicine in terms of ventilator management. How many of you, when you intubate a patient, they're in the ICU within 30 minutes? Nobody. 2 hours. It's STEMI alert, right. Yeah, trauma, or how about 2 hours? How many are out within 2 hours? Okay, wow, that's nice. How many of you have patients that are in there, get signed out multiple shifts, ICU patients in the ED? Yeah, so a few of us, where I am now and when I was at Oakland, you might have a patient in the ED for 30 hours on a ventilator before they got an ICU bed. Now, that's not good for patient care, and that's not the ideal situation. But the point of it is they're going to be there for a period of time in your ED, and so we need to set the vent initially appropriately, and we need to know how to manage the alarms. So this might be some new material for some of you, or a dusting off some material for others. So let's talk about the basics of ventilators. There's 3 modes. You can have a pressure target, you can have a volume target, or a combination of both. Okay. Now 3 types of breaths. One is mandatory, where the vent gives it no matter what. One is assisted, where it helps when the patient takes a breath, and the other is spontaneous, where all it does is just give a little peep and the patient breathes on their own. So 3 types of goals, 3 types of breaths. Using those 6 factors in combination, that's how you set up your ventilator. So the most common is volume targeted. So your default setting for all your RTs, they're going to set up a volume targeted vent settings, and that gives a constant tidal volume, 450, 500. Every breath is 450 or 500 cc's. What it doesn't control is the airway pressure. So your airway pressure is variable depending on the resistance of the lungs. So that rapid delivery of tidal volume, it's not on a ramp, it's essentially like a box shape. So when the vent opens, it has a high flow rate and it fills the lungs up to 500 and then it shuts off. And then it waits and fills the lungs to 500 and shuts off. That filling can have higher airway pressures initially. So sometimes you get higher airway pressures with a volume target than you do with a pressure target. Now again, there's variations that help to minimize that. Default setting, essentially everyone gets started on volume.